This is the second lecture in the series for the 2014 Paramedic Refresher for Trotwood Fire and Rescue. We're going to cover pediatric and respiratory emergencies. So remember, respiratory emergencies are the number one cause of pediatric hospital admissions. They also are the number one cause of death during the first year of life. And of course, that's except for any kind of congenital abnormalities. Keep in mind that most pediatric cardiac arrests, they begin as respiratory failure or respiratory arrest. So these kids, typically they'll start out, the asthma, the croups, the bronchiolitis, the epiglottitis. These kids will start out, just that respiratory difficulty. It'll progress because their air hunger and the O2 consumption has went up, and metabolic rate has went up. They go from the respiratory failure into respiratory arrest, and then they end up into cardiac arrest because of the respiratory arrest or respiratory failure. So just a little bit of A&P for the respiratory system for the pediatric population. Remember, these kids have a large head, they have a small mandible, and they have a small neck. That's why when you lie them flat or supine, typically their head will, they start going into a position where it closes off their airway. That's why we always try to keep them in what we call a sniffing position, so that way it keeps their airway open. They have a large posteriorly placed tongue. You can see right here, their tongue is fairly large, and it takes up quite a bit of the airway, and it's fairly posterior. A very high glottic opening. Because of that high glottic opening, what ends up happening is they're very anterior. It's very hard to see. It does not take much to be able to see their airway. So if you dig down with the laryngoscope and then you're trying to look posteriorly, you're going to end up missing. All you'll see is just the esophagus and not the epiglottis and in turn the trachea. They have very small airways. Their airways are small. That's why we use uncuffed tubes on these patients. Whether it be the 4 or the 3.5 uncuffed tube. Just remember that their airways are very small, so we don't put any kind of cuffed tubes. When we're looking at trying to figure out what size tube we use, remember we're going to use their nair or their little finger. Then the presence of tonsils and adenoids. Because of the presence of tonsils, it's not as big of a deal in the adult population, but in the pediatric population, when their tonsils are swollen from some kind of an infection, that can cause a major respiratory problem and a major airway occlusion. So you need to make sure that if they do have their tonsils and they have some kind of an infection, you may have to end up intubating them, and you may have to control their airway because the tonsils can become an obstruction. Just keep in mind that they have a poor accessory muscle development, so their bodies just aren't developed like an adult, and they can't compensate as well. And that's why these kids will have supraclavicular, they'll have suprasternal, they'll have intercostal retractions, and they'll have the epigastric retractions. They have less rigid thoracic cage. So in other words, like when they breathe, that's why their chest they'll become barrel chested, because they have a less rigid thoracic cage, so their lungs can expand more, so they get more air in. But they also have that, it's just not as rigid. They have the horizontal ribs, and they're primarily diaphragmatic breathers. Because they're diaphragmatic breathers, that's why they're belly breathers, and we'll see, that's why you want to lift up their shirt if their shirt is down, and just see if they're breathing, if they're a primarily belly breather, and if they're a diaphragmatic breather, how much air they're actually taking in. That's a good indication if they're having severe respiratory distress. They have an increased metabolic rate, and they have that increased O2 consumption. So keep in mind, decreased respiratory reserve plus that increased O2 demand, that equals an increased respiratory failure risk, because they don't have as much reserve, plus they're going to be air hungry for oxygen. These kids can go into respiratory failure very easy. So that's why this is a major medical emergency for kids when they have some kind of a pediatric respiratory problem. So you can see the picture on the left-hand side here. You can see the nasal flaring from this kid. You can see where they're tripoding because they're trying to get air. They're in a exaggerated sniffing position, and they have the intercostal retractions. So you can see the intercostal retractions. It's kind of hard to see, but like a supraclavicular retraction. They end up having the suprasternal retractions, and then they have the epigastric retractions. In this child, have the nasal flaring, that poor muscle tone, so you pick up their arm, they're just floppy. The intercostal retractions, supraclavicular retractions, suprasternal, and then also the epigastric retractions. So, some indications of signs and symptoms for respiratory distress in the pediatric population. Tachycardia, that's a big one. It's an early indicator that they're having severe respiratory problems and that they're going to crash fairly easy. Remember, in the neonatal population, that it actually may be bradycardia as opposed to tachycardia. Head bobbing, they just can't keep their head up. They're kind of stuporous. Their head just kind of keeps flopping. They become striders. They have that real high-pitched strider sound. And then they have a prolonged expiration. So they may not have a problem getting air in, but they have a problem getting the air back out. So they're trying to basically push it. It's like trying to push through a straw, trying to breathe through a straw. They have abdominal breathing. Once again, they are primarily diaphragmatic breathers, so they will have abdominal breathing. And then if they're grunting, that creates what's CPAP, or continuous positive airway pressure, or PEEP, which is positive end expiratory pressure. So essentially they take that air in, it opens up their alveoli, and then they can end up with spontaneous pneumos because of that. So we're going to go through just the first 5 respiratory emergencies. We're not going to go through brachiopulmonary dysplasia. So typically we will see croup, epiglottitis, asthma, bronchiolitis, and then the FBA, which is the foreign body aspiration, and then we'll go through foreign body airway obstruction as well. All right, so laryngotracheal bronchitis. That's another big fancy name for croup. Keep in mind that croup is a viral infection, or it's a parainfluenza. It affects the larynx and the trachea, and it's a subglottic edema, and they have a decreased airflow obstruction. So they'll have that, basically the subglottic edema, it will shrink, and so they'll have a hard time getting air in and out, both. It's more prevalent in the 6 month to 4 year old population. It's greater in the male population than the female, and we see it more predominantly in the fall or early winter. Usually the telltale sign, you'll ask mom or dad or grandma or grandpa about, when did all this start, how did it start? They can say, they've had a cold for like a week, a couple weeks, just getting progressively worse. They started getting real hoarse. They've had this chronic cough they can't get rid of. We thought, it would just go away. It just keeps getting worse. And tonight, they've got that. They sound like a seal, or they like a bark when they cough. They're severe respiratory distress. They've been running a low-grade fever. That the little circumoral cyanosis. You don't see cyanosis as often, but one of the big signs is that seal bark cough. And then it'll recur on several nights. So for mild croup, when we come across it, just reassuring the patient and reassuring the care provider. Moist, cool air, so this could be, they teach you that you can open up the freezer door, and just that mist that comes out and the moisture that comes out, that's something that's very, very good for using for the, basically opening up the airways so that the child can breathe. If we run into a child that's having severe croup, you want to give them humidified high concentration of oxygen. You want to make sure you monitor ECG for any kind of tachycardia or bradycardia. If you can start an IV on them, start an IV. If they don't tolerate it, and you do not want to make them anxious, it's okay to go without the IV. Obviously, if they're getting ready to crash, you need to make sure you get an IV or an IO in them. But a child that's maintaining their own airway, their saturations are within a normal limit, you can probably go without the IV. And make sure you anticipate the need to intubate or assist ventilations. So putting a bag valve mask on their face is probably going to cause anxiety if the child is, fully alert and oriented. And then in turn, get your stuff out, get your bag valve mask out, get your intubation equipment out, get yourself ready, because once again, if these kids crash, they're going to crash fairly quick. So now we'll cover epiglottitis. Remember, Epiglottitis is a bacterial infection. It's a Haemophilus influenza. This is affecting the epiglottis and any kind of adjacent pharyngeal tissue, and it's a supraglottic edema. So once the epiglottis gets inflamed, or it looks very cherry red, and if you've ever seen it, you'll never forget it. Very, very cherry red, and it's swollen, which in turn becomes an airway obstruction. So remember, it is a complete airway obstruction when you have an epiglottitis. So once your epiglottis has become inflamed, it becomes a complete airway obstruction. They can't get airway in, or air in, they can't get air out. It's more predominant in the greater than 4-year-old age group, and it's very common in the ages of 4 to 7-year-olds. Now, basically the PD incidence is falling throughout the last few years, and that's because they have the Haemophilia influenza B, or the H flu. What ends up happening is they give them this vaccine. Unfortunately, us as adults, and then obviously particularly the elderly, they are more prevalent, and it's more prevalent in that population now because we never got that vaccine. So you will see this in a higher adult and elderly population than we do in the pediatric population now. Remember, it's a rapid onset and severe distress in hours versus the croup, which is kind of it starts out as a cold, and then they become hoarse, then they start coughing. It's just it's a very slow progression. Epiglottitis, you go from 0 to sick fairly fast. They'll have a high fever, so they're not running that low-grade fever. They'll have an intense sore throat, or what they'll describe as the worst sore throat of their life. They'll have a lot of difficulty swallowing. Because of that difficulty swallowing, you're going to have quite a bit of drool. They can't maintain their secretions, so they'll be drooling. They have that high-pitched stridors, respirations. They will sit up, lean forward, and they'll extend their neck out slightly into a tripod position because they're air hungry and they're just trying to open up their airway. And about 1/3 of these children actually present unconscious or in shock. So, and that could be from the sepsis or from the hypoxia. Respiratory distress plus the sore throat plus the drooling, that's going to equal epiglottitis 99.99999% of the time. So for us, we need to manage this with high concentration of oxygen. If we can put an IV in them, great. If you can't get an IV in them, do not mess with it. This kid needs to get to the hospital fairly fast, because if we try to visualize the airway or we try to intubate them and we can't get them intubated and we stimulate the epiglottis and it now was a partial obstruction, now it's become a complete obstruction, we're going to end up having to crike this kid. The last thing you want to do is try to do any kind of a crike on a child. So you want to make sure that you do not visualize the airway, and we're going to rapid transport to the hospital. It's an immediate life threat and a possible complete airway obstruction. So if you've not seen this before, it's not fun. I've only had one patient with epiglottitis, and thankfully, they weren't extremely critically ill, but they were fairly sick, and we knew that we had something bad because they just weren't able to swallow. They were drooling everywhere, and they had that high-grade fever. All right, so with asthma, that's probably the thing that we're going to see the most from a respiratory standpoint in the pediatric population. Some of the things that trigger asthma, so allergies, this can be seasonal allergies, this can be allergies from a new detergent, this could be pollen, this could be a number of different things, infection, whether it be from a cold, a viral, a bacterial infection, something that triggers it, any kind of irritants, once again like pollutants, chemicals. So if you get somebody that mixes bleach and the works together and it creates some kind of an irritant. Emotional stress, so the elderly population or the younger population that gets emotional stress, they get anxiety, and they're anxious, that can trigger the asthma itself. Cold air, going from a warm atmosphere out to the cold atmosphere can trigger asthma. And then exercise-induced asthma, there's actually a lot of people that suffer from this, unfortunately. And usually they know it, but not everybody knows they have asthma, and it can just strike at different times. So bronchospasm, bronchial edema, and increased mucus production. This is kind of like the perfect storm. This is that triangle all these different things together equals asthma. So remember when I talked about, they say it feels like they're breathing through a straw. So you can see, the normal airway here. It's moved. You got a little bit of airway lining, the muscle, the cartilage. And then once we get a little bit of muscle contraction or that laryngeal edema, and now we've got the laryngeal edema, muscle contraction, and the mucus plugs, and they can barely breathe. So this is like, breathing through, this is just breathing normally. This is like breathing through, a drinking straw. This is like breathing through a stirring straw. So they made a cast of an airway that was produced by an asthmatic mucus plug. Pretty large and in charge. It's pretty nasty, but that just gives you a good idea of like what it looks like with a mucus plug. So no air movement, just kind of expands everything. And if they can't get it, they don't have a hard time getting air in. Asthmatic patients have a hard time getting that air back out. So they basically have air trapping. So some of the signs and symptoms we need to look for, obviously dyspnea. Asthmatic patients are going to have difficulty breathing. Nasal flaring, any kind of tracheal tugging. Tracheal tugging is a good indication for us, for the asthmatic patients, because if they have tracheal tugging, they possibly could end up having a tension pneumothorax. So if they have a pneumothorax and it's now become a tension pneumothorax, we're going to need to decompress them. And that's why, when we talk about the asthmatic patients that go into cardiac arrest, we do a bilateral needle decompression. That's why. It's because they have a hard time getting that air back out. Once they get it in, they get the air trapping, and then they have weak spots in their lung, and then they end up with pneumos. They have accessory muscle use, so they'll have that, once again, the suprasternal, intercostal, and epigastric contractions. So the suprasternal, so right below the Adam's apple, above your chest plate or your chest bone. Your intercostal retraction, so in between your ribs. That epigastric retraction, so and then up underneath, basically where your xiphoid process is. And a lot of times they'll get those suprasternal, not suprasternal, but the supraclavicular retraction, so right around your clavicles, and they just start sucking in. So these people will typically present with coughing. The kids will have expiratory wheezing because, obviously they're having a hard time getting the air back out. They'll be tachypnic or rapid breathing, and they'll have cyanosis, whether it be on the nail beds, or they'll have circummoral cyanosis, which is cyanosis around the mouth or the lips. Asthmatic patients that are having prolonged attacks, so in other words, the status asthmaticus patients, these people will become dehydrated fairly fast, and because they're dehydrated, they have a decreased fluid intake, and they're blowing off all of the water in the respiratory, it's basically all of the mist in the respiratory system. They become dehydrated. Because they're dehydrated, that makes the mucus plugs worse. Once the mucus plug gets bad with the dehydration, it doesn't take long for these people to actually go into cardiac arrest if they've had a prolonged attack and they're in status asthmaticus. So this is definitely a medical emergency. So some questions we need to get if the child's able to answer these, and if they're too young or they're not able to answer them because of their condition, you want to make sure you ask the parents or the care provider. So how long has this patient been wheezing? How much fluid has the patient had today? Any kind of recent respiratory tract infections? Any medications they're on? When do they take them? How much do they take? Do they have any allergies and medications? Or do they have any seasonal allergies or any other kind of allergies that may have triggered this asthma attack? And any kind of previous hospitalizations. We'll get into previous hospitalizations in just a second. That kind of tells you and clues you in on how bad this person could possibly become. So our physical exam, we want to look at the patient positioning. Are they tripoding? Are they in the sniffing position, like an exaggerated sniffing position because of air hunger? Are they drowsy? Are they stuporous? So in other words, is their head bobbing? Are they really drowsy? They're looking through you instead of looking at you. They can't keep their eyes open, or their eyes are deviating to one side or the other. Signs and symptoms of dehydration. So we're looking at just that dry scaly skin or just dry skin, poor skin turgor, dry mucous membranes, so their nose is dry, their tongue's dry, their gums are dry. Look at their chest movement. Is it symmetrical? Is it asymmetrical? Is it symmetrical? They have good rise and fall. How is it moving? Do they have intercostal retractions? they have the supraclavicular retractions, any kind of accessory muscle use, making sure that they don't have any kind of flail segments, and making sure that we're trying to rule out any kind of tension pneumos that they may have, or what's been a cause of the asthma, or I'm sorry, the asthma caused that. So the quality of the breath sounds, are they weak? Are they strong? Is there hyperresonance? In other words, they'll tell you to tap, does it sound like a drum, or is it real dull? If it's dull, that means that there's fluid. If it sounds like a drum, then more likely there's a bunch of air trapping, and we need to get rid of that air. So this is the hospitalization. These are things you need to ask. Any kind of prior ICU admissions. Has this child ever been intubated before? That's a big, big indicator. If they've been intubated before, that means they're probably going to get intubated again. So if they've ended up on a vent before, that means that they're probably going to crash. They're going to deteriorate fairly rapidly, and we need to make sure we're ready. So if they do crash, we're not farting around trying to find our stuff in our bags. We can actually intubate the child fairly quickly, control their airway. If they've had any greater than 3 emergency department visits in the past year, if they've had 2 hospital admissions in the past year, so that's on top of the 3 emergency departments. If they've had 2 hospital admissions from the emergency department, if they've went through greater than 1 bronchodilator canister in the past month, if they have to use a bronchodilator or their metered dose, then greater than every 4 hours. Excuse me. If they have any kind of chronic use of steroids, or if the progressive symptoms, even when they have had treatment. So if they've had any kind of prescriptions and they still are having progressive symptoms and it's not making it any better and they're just getting sicker, you need to make sure that you get these children loaded up, get them to the hospital rapidly. Unless you lose your airway, you need to bypass Good Sam, bypass Grandview, bypass Miami Valley. This child needs to get to Children's Hospital because they're going to be the people that are going to give this child the best care possible. Alright, so it says silent chest equals danger. If you can't hear breath sounds and the child is having a lot of respiratory problems and their pulse oximetry is in the crapper, this is a bad thing. This equals danger, and you need to make sure that you're ready to intubate these children fairly fast. Alright, so all that wheezes is not asthma. So there are many other conditions that mimic asthma that causes wheezes. So the first one, pulmonary edema. I think we all know that typically we're listening for that wet sound, so that could be pneumonia or pulmonary edema. We're not sure. But also with pulmonary edema, they have wheezing. They'll have that expiratory and inspiratory wheezing. So just because you've got the wheezing doesn't necessarily mean that it is asthma. It may be pulmonary edema, so you may have to dig a little bit deeper to make sure that you're not missing something. Any kind of allergic reactions. So if they are having an allergic reaction, it may not necessarily be asthma. It may just be that they've had an allergic reaction to something. In other words, like anaphylaxis. So pneumonia. Pneumonia is a big one. You get these patients that they have a fever, they're dehydrated, and they're wheezing. It could be pneumonia, not necessarily asthma. So for us, there's not a lot that we're going to do differently. We're still going to give them bronchodilators. We're going to give them the Atrovents. We're still going to give them albuterol. Remember, with pulmonary edema, we actually have changed our congestive heart failure protocol, and we no longer are giving the morphine. We can give them bronchodilators, and we can give them the nitro. Obviously not in the pediatric population, it's the adult population I'm talking about now. But in the pediatric population for pulmonary edema, so have they had any, did they have a near drowning? Have they had any kind of fluid intake? In other words, like an aspirational edema. So foreign body aspiration. So, the child that was eating, they didn't swallow their food well, or the pediatric, patient that mom and dad was feeding, and they sucked in some of the baby food. Now they get a foreign body aspiration. So they get that gunk in their lungs, and it sounds like they're wheezing. All right, so management for asthma for us, Obviously, we're going to control the airway. We always worry about the airway. That's number one for us with the asthma patient. Breathing. Make sure you keep them in a sitting position. Don't lie them down. Give them a sitting position. If you have humidified oxygen, give them humidified oxygen by non-rebreather. Just remember that if we're giving them dry oxygen, that can dry out the mucous membranes and actually make the plugs worse. So always encourage coughing. You want them to cough up anything that they may have, because it may end up being those mucus plugs that they can get rid of. Will help actually expand their lungs so they can breathe. Again, consider intubation, and if you have to assist ventilations, assist ventilations. Get your stuff ready, because when these children crash, they're going to crash fairly fast. So for circulation, we're going to try to start IVs on them if they can tolerate it. Make sure that you assess them for dehydration. This is, out of all of them, this is probably the most important to get an IV in, because they're dehydrated, because of the mucus plugs. You don't want this to dry out. Titrate your fluid administration is the severity of the dehydration, so you don't want to dump a bunch of fluids into them. So give them just enough fluid to make them so they're hydrated. And then monitor their ECG. It's very important. Obtain any kind of medical history or medication history, any kind of overdoses or arrhythmias that they may have. Just because if we give them the wrong medication, we need to make sure that we're not giving the wrong medication, or if they've got any kind of allergies medications, and then any kind of arrhythmias. If we're giving them a bronchodilator, so like albuterol, we know that albuterol increases heart rate. So if the child's got a past medical history or comorbidity, and they've got an arrhythmia, then we need to make sure that we are cognizant of giving them a bronchodilator like albuterol, which is going to in turn increase their heart rate, and if they have an arrhythmia, then we can make it worse. So we're going to give the albuterol. We also give them Atrovent in addition to this. In severe asthma, we can give subcutaneous epinephrine. Remember, we're giving 1 to 1,000. We're giving anywhere from 0.1 to 0.3 milligrams, and it's no longer sub-Q, so we give it IM. And then the possible benefit in the patients with ventilatory failure. I kept the sub-Q just because we have not started our 2014 protocols yet until after we take our written test. So I just kept it in there. But just keep in mind I had switched to IM. And possible benefit in the patients with ventilatory failure. So if they're going into failure, this is basically a high dose, and we need to make sure that we give the child the epinephrine in severe asthma. So things we want to avoid in asthma, we want to make sure that we do not give them any kind of sedatives. No Verseds, no Valiums, no fentanyls, because that can depress the respiratory drive in these patients. Try to avoid any kind of antihistamines. One, it'll decrease their level of consciousness, so Benadryl, we know it doesn't affect everybody the same way, but it affects a lot of people by making them sleepy. It also will dry out their secretion, so it'll make those mucus plugs a lot worse. And then we're avoiding aspirin. So it has a high incidence of allergy. A lot of people are allergic to aspirin, so we do not want to give aspirin just because of the potential for allergies, that they may not know that they have an allergy to it until after you give it to them. So we talked about status asthmaticus a little bit. Just remember the definition of status asthmaticus is an asthma attack. It's unresponsive to beta-2 adrenergic agents. So you're pumping in albuterol to them, you're pumping the Atrovent into them, and it's not doing anything, and it's not relieving that asthma attack, and it just continues, or it goes from one after another after another after another. That's the definition of status asthmaticus. That is a medical emergency. Right. What we want to do is make sure we give humidified oxygen if it's available. Try to rehydrate them as much as you can. Give continuous nebulized beta-2 agents, so in other words, albuterol. And we continue the Atrovent. Intubation is imperative here. If they can't control their own airway, you need to make sure that you intubate these patients. Trying to force air into them is not going to help a tremendous amount, because they're not going to be able to get that air back out. And then putting them on a mechanical ventilator. So once they get them to the hospital, they're going to have large tidal volumes and that long expiratory times. So they want to basically increase their expiratory time so it gets all the air out. And then they also want to make sure that they have a large tidal volume. They typically do about 18 to 24 milliliters per kilogram per air. All right, so bronchiolitis. Remember, bronchiolitis is a viral infection. This is, the RSV. We do see this quite a bit. It's inflammatory bronchial edema, and they start getting air trapping. In other words, they get the air in, and they can't get it back out. It's more prominent in the pediatric population of less than 2 years old. About 80% of the patients are less than 1 year old, and the epidemic between January through May. Remember, infants a little less than 1 year old, these are the ones we're looking for, and this is just kind of an indicator to us. Recent upper respiratory infection exposure. They have a gradual onset of the respiratory distress. Any kind of expiratory wheezing, the extreme tachypnea, so these kids could be breathing anywhere from 60 to 100 times a minute, and they have that cyanosis, whether it be on the nail beds or the circummoral cyanosis. I remember my oldest nephew now, who's 22, or he'll be 22 soon, when he was, I think, like 9 months old, very, very sick. Had to be, what I would consider an incubator. He had to be in the oxygen tent. Very, very ill. And so these kids, they get better. A lot of them get better, but, some of them don't. And they will get sick. And when they get sick rapidly. So just comparing apples and oranges with asthma versus bronchiolitis. Asthma is usually greater than 2 years. Bronchiolitis is usually less than 2 years old. Fever is usually normal in the asthma patient, and bronchiolitis patients do have a fever because of that viral infection. A lot of times the asthma patient will have a family history of asthma, where the bronchiolitis patient, there's usually no family history. It's not a genetic disease. For an asthma patient, usually they'll have a history of allergy problems or any kind of problems, being allergic to or having allergies, whether it be to pollen or seasonal allergies or to new products that they're using for laundry. And then bronchiolitis has nothing to do with allergies. Asthma patients are typically responsive to epinephrine. The bronchiolitis patients are negative to epinephrine, so the epinephrine is not going to do anything for them. So what can we do for bronchiolitis? We can give them humidified oxygen by non-air breather. We're going to monitor their ECG. We're going to start an IV on these children. We need to make sure we anticipate giving them albuterol or Atrovent, and make sure that we get our intubation equipment out. Every one of these, you have to be ready. Get your bag valve out. Get your intubation equipment out. Take somebody extra with you in the back of the medic while you're going to the hospital, because I can't say it again, it's imperative. These children, when they crash, they're going to crash quick. Alright, so foreign body airway obstruction. 90% of the deaths in the children population less than 5 years old. So that's a pretty big number. Now this is from toys. This can be from food. It could be from a tongue, because remember they have those giant tongues. And it accounts for 65% of the deaths in the infant population. So suspecting any kind of previously well, afebrile child with a sudden onset of respiratory distress, or choking, coughing, stridor, or wheezing. So the child just basically, they were fine. Now all of a sudden, they have severe respiratory distress. They're choking on something. They're coughing. They have the high-pitched, stridorous respirations, or they're wheezing, and they don't have a temperature. So that should be a big clue to us. So we want to minimize the intervention of the child's conscious, and we want to maintain their own airway. Try not to stimulate them or make them anxious or scare them, because if they have a little bit of air movement, that's better than no air movement. But you start making them anxious, that could constrict everything, and that what low air movement you had, you may lose. Give them 100% oxygen if it's tolerated. If they don't tolerate it and they're moving air, let them go. We do not stick our fingers in their mouth. No blind finger sweeps. Any kind of wheezing. So if the object's in the small airway, and then avoid trying to dislodge in the field. So unless you can, you physically see it and you can take it out, that's the only time that you ever should mess with it. Other than that, leave it where it's at. unless it's becoming a complete airway obstruction and you need to remove it through thoracolaryngiscopy. So if they are not ventilating properly, they have inadequate ventilations, for the infant population, we give them 5 back blows to 5 chest thrusts. The child, we can start abdominal thrusts on them. Okay, so that's the end of the slideshow. What we're going to do now, so this would have been the last lecture for the first day of class, which was January the 11th. You now are able to take the the quizzes on QuizStar. So follow the directions for logging into QuizStar. Take the quiz over all the lectures that we did on January 11th. And if you have any questions, by all means, you call my cell phone or you can email me. Thank you.